Here is a classic pattern of an infarct to a kidney. Grossly, you could see on a cut section that the renal infarcts are wedge-shaped infarcts, and they are anemic, or at least not hemorrhagic. You could call them white, although this one looks a little bit yellow, because they don't have a lot of collateral arterial circulation. They're classically end arteries. Microscopically, you could see in this area of the kidney, whereas you can see some differentiation between tubules and glomeruli here, there basically is a loss of cellular definition. Remember, we called that coagulative necrosis. And in the larger gross specimen, we could see that there is a large area of abnormality in the middle of the kidney, perhaps where there's a lot of loss or necrosis, or maybe even scarring perhaps of the cortex. But this is only a regional effect rather than an entire kidney effect. So we have to theorize that it was only the part of the kidney that was supplied by, whichever blood vessel goes to, or vessels go to the middle third. Let's look at the heart now. And in an infarct to a heart, we could see in the fairly early stages infiltration of neutrophils and loss of nuclei. Grossly, infarcts of the heart in the early stages can look yellowish or purplish. With time, they become scar tissue. So if you see whitish tissue regionally in the wall of a heart, perhaps in this transmural or involving the entire wall of the ventricle. If it's really white and gritty, it's probably old. If it's yellowish, it may be organizing. Most of the early infarcts are soft and purplish. So you can go by gross appearance or microscopic appearances. This one certainly is recent because of the neutrophils and loss of nuclei. To tell you the truth, I don't know what this one is, but I can only see that it's white, and if it's white because of scar tissue, we know that it's old, which means months to years. We talked about infarcts as involving organs or parts of organs, but if you theorize that there was circulatory collapse or inadequate blood flow to the whole body, that's what we call shock. And classically, shock can be divided into inadequate total body blood flow on the basis of cardiac problems, or on the basis of sepsis, what they call septic shock, secondary usually to bacterial endo or exotoxins, as well as hypovolemic shock, where perhaps there's been no infection and your heart is good, but you lost your vascular volume to a wide variety of reasons. So these are the three classical reasons for shock. There's a couple of others I might mention. We're going to look at the morphology of shock and the clinical course of shock as well. Shock is cardiovascular collapse, whether it's due to the heart, the blood vessels, or a bacteria acting in overwhelming sepsis. The common pathophysiologic features are either inadequate cardiac output to perfuse the entire body and or inadequate blood volume. The overall general result is total body inadequate tissue perfusion, or if you want to think of it as inadequate perfusion of vital organs, of course, and ultimately cellular hypoxia, death, and the kinds of things we talked about in Chapter 1. Shock is very serious, has a high mortality, and as you would guess, total body inadequate perfusion would almost certainly have a fatal outcome unless it could possibly be corrected in only the early stages. In the latest stage, there's nothing you could do. It is pre-death. Let's talk about the three different kinds of shock. Cardiogenic shock can be acute or chronic. Hypovolemic shock can be due to hemorrhage or leakage of fluid in other ways. An endotoxic shock, which is the same as septic shock, the number one killer in ICU, is generally the third type. Theoretically, if you had neurogenic shock, the autonomic innervation of your blood vessels collapses for some reason, and you have loss of vascular tone. That could be another explanation. And often the term anaphylactic shock is associated with IgE-mediated generalized systemic vasodilatation, and therefore increased total body vascular permeability. These can also, and usually are, or often are, fatal as well. But let's go into the three main categories. Why can your heart fail acutely? How about a myocardial infarction? How about a ventricular rupture secondary to a myocardial infarction or other reason, perhaps even traumatic? Perhaps a significant arrhythmia resulting in pump failure? Perhaps external compression to the heart, pericarditis or pericardial effusion, causing cardiac tamponade or significant external compression, or a very significant acute right heart failure with a large pulmonary embolism, which we've just described. In hypovolemic shock, you lose your fluid. In significant hemorrhage, your vascular compartment leaks fluid. In vomiting, you lose fluid and electrolytes as another mechanism for losing massive amounts of fluid. Even with diarrhea, we have massive fluid loss. That could result in hypovolemic shock too, and it does in many of these fatal diarrheal illnesses like typhoid fever. Burns can also result in extensive leakage of fluid because of lack of things like skin to hold your water in. So these are all the common mechanisms for hypovolemic shock, and any one of them is possible. And the third type of shock, septic shock, often called endotoxic shock, which is usually gram-negative endotoxins, also termed LPS for lipopolysaccharides, because that's what they are chemically. You can also have a gram-positive shock. You can also have shock due to overwhelming fungal infection as well. You know, there's this concept of superdelegates this year with the elections going on, so let's introduce a new concept called superantigens as well, kind of a relatively new concept in medicine, especially classically seen in the toxic shock syndrome. So superantigens technically are activators of T lymphocytes that induce massive systemic inflammatory cytokine cascades, like we saw. Now, in septic shock, it's staph that is the ultimate producer of this whole cascade, and that's what an example of gram-positive organisms producing septic shock. What are the sequence of events in septic shock? In other words, overwhelming infection, vascular collapse. Well, the first event is peripheral vasodilatation, and therefore loss of vascular tone, and then pooling of blood, and therefore loss of circulation for that reason. And remember what happens with pooling and abnormal flow. The endothelium gets activated. There could be massive DIC going on secondary to the endothelial activation. If you want to think of this whole event as a total body inflammatory response, you can, because that's what septic shock is. And we have only a few seconds left, so let's stop right here, and we'll talk about some more types of septic and other shock in the next 10-minute batch. And I thank you very much.